Okay, welcome to immunologic diseases, which is one of those topics that students either love or fear or both at the same time. If immunity ever felt abstract before, this is where it becomes very real, very fast. Because the immune system doesn't just protect tissue, sometimes it absolutely wrecks it. And then we're the ones processing, cutting, and staining the aftermath. This lecture is part of clinical pathophysiology, so our goal is not to turn you into immunologists. Our goal is to help you recognize how immune mechanisms change tissue structure, cell population, and staining patterns, because that's what lands on your slides. Quick reminder before we go further, these PowerPoints are supplemental. They highlight key ideas, visuals, and patterns, but the textbook contains more detail, more examples, and more nuance. If it's in the book but not on the slide, it is still fair game for quizzes and exams. Think of the PowerPoint as the movie trailer. The textbook is the full film with bonus scenes and director commentary. Here's what I want you to walk away with after this lecture. Not memorized, but understood. First, you should be able to list the major functions of the 5 classes of immunoglobulins. Not just IgG exists, but what it does, where it acts, and why it matters in tissue. Second, and this is where histotechnology really comes in, you should be able to recognize lesions and manifestations associated with the 4 types of hypersensitivity reactions. You are not expected to diagnose disease clinically, but you are expected to look at tissue and think, this looks immune-mediated. This feels acute versus chronic. This pattern fits better with antibody involvement than T-cell mediated injury. And yes, type 1 through type 4 hypersensitivities can absolutely blur together if you approach them as a memorization exercise. We're going to approach them as mechanism. It turns into tissue change, which equals histologic pattern. If you can follow that chain, the material becomes much easier and much more useful in practice. Before we talk about what goes wrong, we need to remind ourselves what normal looks like, because pathology is really just normal biology having a bad day. We start with immunity, which breaks into 2 big categories. Innate immunity is your first responder. It's fast, nonspecific, and has zero interest in remembering anything about you. Neutrophils, macrophages, natural killer cells, these are the immune system version of, I don't know who you are, but I don't trust you. Histologically, innate immunity often shows up as neutrophil-heavy infiltrates, edema, vascular congestion, and tissue disruption that looks chaotic. Adaptive immunity, on the other hand, is slower but much smarter. This is where specificity, memory, and targeted destruction come into play, mainly through B cells and T cells. Adaptive responses often correlate with lymphocytic infiltrates, organized inflammation, and chronic patterns rather than explosive ones. An antigen is anything recognized as foreign. That could be a pathogen, a toxin, a drug, or in autoimmune disease, something that absolutely should not be considered foreign, but is anyway. And just to clear up a very common misconception, antigens are not antibodies. Antigens trigger the response. Antibodies respond. The epitope is the specific site on an antigen that an antibody binds to. Think of the antigen as the whole puzzle, and the epitope as the one oddly shaped piece the antibody actually grabs. This matters because epitope binding determines specificity, strength of immune response, and whether immune complexes form and deposit in tissue. Immunoglobulins, aka antibodies, are produced by plasma cells which come from B lymphocytes. T cells come from the thymus and include T helper cells, which we also refer to as the coordinators. Cytotoxic T cells are the executioners. Regulatory suppressor cells are the let's calm this down crowd. And then we have natural killer or NK cells. which are kind of the immune system's wild card. They don't need prior sensitization and are particularly important in viral infections and tumor surveillance. From a histotech standpoint, the cell populations present matter just as much as the tissue architecture. Seeing neutrophils versus lymphocytes versus plasma cells tells a story, sometimes before clinical data ever does. And here's a gentle reminder worth repeating. If you don't see something written on a slide, check the textbook, check the lecture narration. Assume it's still important. Slides, again, are supporting characters. The textbook is still the main character. All right, this slide looks busy, but don't panic. Immunoglobulins are one of those things that feel overwhelming until you stop trying to memorize everything at once and instead focus on what they do and where they show up. There are 5 major classes, and each one has a slightly different job description. Let's start with IgA. IgA is all about mucosal protection. Think of IgA as the immune system's bouncer at the club entrance. It works at surfaces before pathogens ever get inside. You'll find IgA in saliva, tears, breast milk, and GI and respiratory secretions. Histologically, IgA matters because mucosal immune responses often don't look like classic inflammation. You may not see dramatic necrosis or heavy neutrophils, but something is happening. IgG. IgG is the most abundant immunoglobulin, making up about 70 to 75% of circulating antibodies. 2 key things to remember. It can cross the placenta, and it provides early protection in newborns. Some worthless but useful knowledge: if you see immune complex mediated disease, IgG is often part of that story. It loves to bind antigen and then, unfortunately, stick around in tissues longer than it should. IgM. IgM is the first antibody on the scene during an immune response. It's big, it's loud, and it's very good at activating complement, causing agglutination, and triggering bacteriolysis. IgM is also found on the surface of immature B cells, which is a very good reminder that not all antibodies are floating freely in serum. We have IgD. IgD is the quiet one. Low concentration in serum. It's mostly found on B cell surfaces, and it's involved in regulating immune responses. You don't see IgD come up often clinically, but it shows up in exams just enough to keep you humble. IgM. IgM is the troublemaker. Low levels in normal serum, but when it binds mast cells and basophils, it becomes responsible for allergic reactions, some parasitic responses, and anaphylaxis. Histologically, IgE-mediated reactions often correlate with mast cells, basophils, and eosinophils. If you see eosinophils, your brain should immediately whisper, "Is IgE involved here?" Slide is your big picture roadmap for hypersensitivity reactions. Instead of memorizing disease names, focus on patterns. Type 1 is atopic or immediate. These are your classic allergies, so allergic rhinitis, which is hay fever, asthma, or urticaria, which is hives. Mechanism-wise, these are IgE mediated and involve mast cell degranulation. Histologically, you may see edema, increased mucus, eosinophils, and smooth muscle contraction effects. Type 2 are cytotoxic. This is antibody-mediated cell destruction. So classic examples would be transfusion reactions, erythroblastosis fetalis. These diseases target cells themselves, often via complement activation. In tissue, this can look like cell lysis or inflammation localized to specific cell populations. Then there's type 3 immune complex. Here's where immune complexes form and then deposit in tissues. Examples include glomerulonephritis, cryoglobulinemia, and lupus erythematosus. Histologically, type 3 reactions are often associated with vascular inflammation, basement membrane involvement, and granular immune deposits, often highlighted by immunofluorescence. Type 4, which is cell-mediated, this is T-cell driven, not antibody driven. So examples would be contact dermatitis, graft rejection, or some immune deficiencies. Histologically, you're thinking lymphocytes, macrophages, delayed response patterns. No antibody needed, just very determined T cells. Now we zoom in on type 1 hypersensitivity, also known as anaphylactic or atopic allergy. This is the classic immediate reaction, and yes, immediate means minutes, not hours or days. Here's the sequence. Allergen exposure, IgE production, IgE binds mast cells. Then we have re-exposure, which equals mast cell degranulation. We have release of vasoactive chemicals. Those chemicals like histamine cause vasodilation, increased vascular permeability, smooth muscle contraction, and muscle secretion. Histologically, this can translate into edematous tissue, dilated blood vessels, eosinophil infiltration, and there's relatively little structural damage early on. Fun fact, but not useless, in fatal anaphylaxis you may see very little dramatic histology because death occurs due to systemic physiologic collapse, not prolonged tissue injury. So sometimes when you don't see on a slide, it's just as important as what you do. This slide brings type 1 hypersensitivity into the real world, where patients, tissues, and histology all start telling the same story. Let's start with asthma. Asthma is type 1. From a mechanism standpoint, this is classic IgE-mediated mast cell activation. From a tissue standpoint, it's a perfect example of how immune reactions remodel structure over time. Histologic lesions you might see include bronchial smooth muscle spasms, thick bronchial walls, increased mucus production, and eosinophil-rich inflammatory infiltrates. Over time, chronic asthma can actually change airway architecture. So what started as a functional problem becomes a structural one. That's important when you're processing lung tissue and wondering why everything looks narrowed, edematous, and angry. Clinically, this translates into wheezing, dyspnea, and cough. But histologically, your clues are eosinophils, mucus, and wall thickening. Now, compare that to allergic rhinitis. Same hypersensitivity type, just different tissue. So allergic rhinitis is still type 1, and it's in the nasal mucosa. Type 1 reactions produce edematous mucosa, eosinophilic infiltration, and increased secretions. Later on, repeated inflammation can lead to nasal polyps, which are essentially the tissue saying, fine, I give up, I'll just stay swollen. Manifestations include nasal discharge, partial obstruction, complications like sinusitis and otitis media. Again, the same immune mechanism, but different tissue and different histologic patterns. And that's a recurring theme in this course, if you haven't noticed that by now. Slide reinforces an important concept. Type 1 hypersensitivity isn't just one disease. It's a mechanism that can show up in multiple ways. Urticaria, or hives, is essentially localized edema of the dermis. Histologically, we'll see dilated blood vessels, increased vascular permeability, and minimal structural damage. Clinically, you see raised red wheals, pruritic patches, These changes can look dramatic on the skin, but microscopically they're often pretty subtle. Angioedema is the most severe, is the more serious cousin. Sorry about that. Instead of staying superficial, the edema becomes generalized, deeper, and potentially dangerous. When this involves the tongue, lips, or larynx, airway obstruction becomes a real risk. From a histology standpoint, you're still seeing edema and vascular changes, but the clinical stakes are much higher. Systemic anaphylaxis. This is where type 1 hypersensitivity becomes life-threatening. Lesions include bronchospasm, widespread vasodilation, and urticaria. Manifestations include itching and flushing, hypotension and shock, loss of consciousness, and difficulty breathing. Here's an important histotech takeaway. In fatal anaphylaxis, tissue findings may be surprisingly minimal. Death occurs due to rapid physiologic collapse, not prolonged tissue destruction. So if a slide looks underwhelming, that doesn't mean nothing happened. This slide is a nice visual reminder of how mechanism becomes diagnosis. The skin test is the classic diagnostic tool for type 1 hypersensitivity. So here's what's happening. Small amounts of allergen are introduced into the skin. If IgE is present and mast cells are sensitized, mast cell degranulation occurs locally. The result? You'd have localized edema, redness, and the wheel and flare reaction. Histologically, this mirrors what we've been talking about all along: increased vascular permeability, vasodilation, and mediator release. And yes, that cartoon on the right is intentionally dramatic, but it's actually quite accurate. Mast cells don't think, they just react. Once triggered, they release vasoactive amines, lipid mediators, and cytokines, which then affect blood vessels, smooth muscle, and the epithelium. That chain reaction explains everything you see clinically and histologically in type 1 hypersensitivity. Okay, welcome to type 2 hypersensitivity, also known as cytotoxic hypersensitivity. And yes, this is one of the most histotech relevant immune reactions you'll see. The key idea here is simple but very powerful. Antibodies are targeting cells that belong to the host, not immune complexes floating around, not mast cells exploding. Actual cells are being marked for destruction. Mechanisms include agglutination, phagocytosis, complement-mediated lysis, and antibody-dependent cellular cytotoxicity, also known as ADCC. In other words, antibodies bind to antigens on cell surfaces, and then the immune system says, cool, that cell has to go. From a tissue standpoint, this leads to a loss of specific cell populations, evidence of hemolysis or cell destruction, and inflammatory responses tied directly to cell injury. If you're looking at tissue and thinking, why are these cells gone? Type 2 hypersensitivity should be on your differential radar. Now let's put type 2 hypersensitivity into context with real examples you are almost guaranteed to see again. That being on exams, on clinical discussions, or even the AP board certification. Erythroblastosis fetalis. This occurs when an Rh-negative mother develops antibodies against Rh-positive fetal red blood cells. Those maternal antibodies cross the placenta and bind fetal red cells. Histologically, this results in hemolyzed fetal red blood cells, increased bilirubin, and compensatory hematopoiesis. Clinically, manifestations include anemia, edema, and jaundice. And yes, this is associated with a positive Coombs test, which we'll talk about more on the next slide. Blood transfusion reactions. This is another classic type 2 reaction and a great reminder that compatibility matters. The cause is incompatible ABO or RH blood. Lesions, we see hemolysis of recipient red blood cells. The manifestations would result in chills, fever, and possibly renal failure. From a histotech perspective, this is all about red blood cell destruction, free hemoglobin, and downstream tissue effects, especially in the kidneys. And again, a positive Coombs test. So if antibodies are bound to red cells, Coombs test will find them. This slide ties together mechanism, morphology, and laboratory testing, which is exactly the kind of integration we want you to practice. So direct Coombs test or direct antiglobulin test. This test asks, are antibodies or complement already attached to the patient's red blood cells? So the process, the patient's red blood cells are washed, anti-human globulin is added, so agglutination. If there's agglutination, that's positive result. A positive direct Coombs test means antibodies are already bound to red blood cells, so active immune-mediated hemolysis is occurring. An indirect Coombs test, this test asks a slightly different question. Are there antibodies in the patient's serum that could bind to red cells? The process here is the patient's serum is mixed with donor red blood cells. Again, the anti-human globulin is added. If we have agglutination, then we have a positive result. This test is especially important for blood transfusion screening and prenatal testing. And why this matters for histotechnology is even though these are blood bank tests, the downstream effects show up in tissue in the form of hemolysis, pigment deposition, renal tubular injury, and even inflammatory changes. Understanding the test helps you understand why the tissue looks the way it does. So if you remember nothing else, type 2 is antibodies targeting host cells. This leads to cell destruction, often involves complement, and is diagnosed using Coombs testing. And yes, there is more detail in the textbook about subclasses of antibodies, pathways, and variations. Again, if it's in the book, it still matters, even if it's not spelled out on these slides. Now we're moving into type 3 hypersensitivity, which is fundamentally different from types 1 and 2 in where the damage occurs. Type 3 hypersensitivity is an immune complex mediated reaction. Instead of antibodies binding directly to cells or tissues, antibody-antigen complexes form in circulation and then deposit in tissues. Once those immune complexes settle in places like small blood vessels, glomeruli, joints, or even the skin, they activate the complement system. That complement activation attracts neutrophils. And here's the problem. Neutrophils try to phagocytose immune complexes that are fixed in tissue, which leads to the release of liposomal enzymes into surrounding structures. The result is inflammation, vascular injury, and tissue damage. Not because the immune system failed, but because it's reacting too strongly and in the wrong location. One important timing point. Type 3 reactions do not happen immediately. They often take several days to develop, which helps distinguish them from type 1 hypersensitivity. From a histopathology standpoint, this explains why we often see vasculitis, neutrophilic infiltrates, and immune complex deposition along vessel walls or basement membranes. Keep that mechanism in mind. It will matter when we look at renal disease patterns later. Now let's look at clinical examples of type 3 hypersensitivity so you can connect the mechanism to disease. First thing we have is something called serum sickness. Serum sickness is a classic type 3 reaction. It occurs when the body is exposed to foreign proteins, historically horse serum, but today more commonly certain drugs. Here's what happens. Antibodies form against the foreign antigen. Immune complexes circulate. Those complexes deposit in small blood vessels, and the resulting lesion is acute vasculitis caused by complement activation and neutrophil-mediated injury. Clinically, patients may present with fever, painful joints, enlarged lymph nodes and spleen, and urticaria. These symptoms make sense when you remember this is a systemic immune complex disease, not a localized reaction. And then we have something called polyarteritis nodosa. Polyarteritis nodosa is another type 3 hypersensitivity disorder, but it's more severe and much rarer. This disease involves widespread, multifocal, necrotizing vasculitis, typically affecting medium-sized arteries. Because multiple vessels are involved, symptoms vary depending on which organs lose blood supply. From a pathology perspective, this explains why polyarteritis nodosa often presents within patchy tissue necrosis, ischemic injury, and inflammation centered on vessels. This is a great example of how immune complex deposition directly translates into structural damage you can see under the microscope. When we suspect type 3 hypersensitivity, we are not just looking for antibodies in the blood. Instead, we're trying to demonstrate immune complex deposition in tissues. And that's where immunofluorescence, or IF, comes into play. Immunofluorescence can be direct or indirect, but the goal is the same: to visualize immune complexes using fluorescently labeled antibodies. A classic example is the renal glomerulus, where immune complexes deposit along the basement membrane. Instead of smooth, linear staining, type 3 reactions show a granular or lumpy, bumpy pattern, which reflects scattered immune complex deposits. This pattern is a major diagnostic clue. We also have immunohistochemistry, or IHC. Immunohistochemistry is often used to detect complement components, particularly C3 and C4, within tissue sections. Positive staining for complement supports immune complex deposition, complement activation, and immune-mediated tissue injury. In glomerular disease, these findings help confirm that damage is immune complex driven, not simply inflammatory or degenerative. Key takeaways is for type 3 hypersensitivity, always think immune complexes, complement activation, delayed onset, vascular and glomerular injury, and granular IF patterns. If you can connect those dots, you'll be able to interpret both clinical descriptions and histologic findings accurately. Slide is your why histology matters in immunology moment. When we talk about type 3 hypersensitivity, we are talking about immune complexes floating around, depositing where they absolutely should not be, and then lighting up inflammation like a bad group project gone wrong. Antinuclear antibodies, or ANA. ANA testing is most commonly associated with systemic lupus erythematosus, or SLE, a classic immune complex disease. Here's the key histotechnology takeaway. ANA tests are serologic. The tissue damage is histologic. Immune complexes deposit in glomeruli, skin, joints, and blood vessels. These deposits activate complement. They are recruiting neutrophils that release enzymes and cause structural damage. On histology, especially on renal biopsies, you'll see thickened capillary loops, like wire loop glomerulonephritis and severe lupus. IF shows granular immune complex deposition, not smooth, not linear, but very granular. Some worthless but useful knowledge. If IF staining looks like someone sprinkled glitter everywhere, you're probably dealing with immune complexes. Linear patterns are a different party. And we have rheumatoid arthritis, or rheumatoid factor, or RF. RF is associated with rheumatoid arthritis, another immune complex driven process. RF is an antibody against antibodies. Yes, antibodies beefing with other antibodies. It's very on brand. Histologically, you'll see chronic inflammation of synovium, pannus formation, so thick, aggressive granulation tissue, and then you'll see progressive cartilage erosion and bone destruction. From a histotech lens, you're not diagnosing RA on H&E alone, but you are seeing the downstream consequences: tissue thickening, inflammatory infiltrates, and structural loss. So the bottom line for this slide is that serology tells the story, histology shows the damage. Your stains and sections are where immune chaos becomes visible. Welcome to type 4 hypersensitivity. This is where antibodies are politely asked to leave the room. This is T-cell driven, not antibody mediated, and it is slow, deliberate, and destructive. Think of type 4 as, I'm not mad immediately, but give me 48 to 72 hours and I'll ruin your tissue architecture. The mechanism behind it is we have sensitized T lymphocytes recognize the antigen. They release the cytokines. They recruit macrophages, and that causes chronic inflammation and tissue injury. There are no immune complexes, no complement cascade, just cell-to-cell destruction. Some histologic features. This is where histotechnology really shines. You'll see some dense lymphocytic infiltrates, some macrophage accumulation, and tissue architecture destruction. In chronic cases, we may see fibrosis. Unlike type 1, 2, and 3, you won't see immune deposits lighting up on IM. Instead, you see cells doing damage the old-fashioned way. A fun analogy: type 1 is a grenade, type 2 is a targeted missile, type 3 is shrapnel everywhere, and type 4 is a slow demolition crew with clipboards. We have contact dermatitis, which is classic, common, and histologically satisfying. So causes include poison ivy, drugs, cosmetics, dyes, and even metals. Hello, nickel. Some histologic changes on skin sections: expect to see epidermal spongiosis or intracellular edema, lymphocytes migrating into the epidermis. If it's chronic exposure, we may see epidermal hyperplasia, and we also see dermal inflammation. Clinically, it itches. Histologically, it swells, separates, and inflames. As a histotech, if you see spongiosis plus lymphocytes and the clinical history screams new soap, then we're in type 4 territory. Also, we see graft rejection. This is where we turn it up to 11. Graft rejection is type 4 hypersensitivity with real consequences. So the mechanism behind it is recipient T cells recognize donor antigens. The cytotoxic T cells attack the graft tissue, and blood vessels are targeted early. Histologic hallmarks that we'll see are lymphocytic infiltration of vessel walls. We'll see some epithelial damage, ischemia of graft tissue, and progressive necrosis if unchecked. This is why biopsies matter. Rejection often starts microscopically. Histology detects changes before gross failure. Some worthless but pretty cool knowledge: pathologists can often identify rejection before lab values spike, purely based on cellular patterns. Okay, this slide gives us a classic example of type 4 hypersensitivity, and it's one you've all heard about even if you've never personally had it done, and that is the TB skin test, also called the Mantoux test. This is not an antibody-based reaction. No IgE, no IgG, no immune complexes floating around causing chaos. This is purely cell-mediated, which means T lymphocytes are doing the work and they take their sweet time. That's why type 4 reactions are called delayed hypersensitivity. Nothing dramatic happens immediately. Here's what's happening at the tissue level. A small amount of tuberculin antigen is injected into the dermis. If the person has been exposed to Mycobacterium tuberculosis in the past or vaccinated with BCG, their immune system already has sensitized T helper cells hanging out in the background, like, oh hey, I remember you. Those T cells don't kill anything directly. Instead, they release cytokines, basically inflammatory group texts, that recruit macrophages and other inflammatory cells to the site. Over 24 to 72 hours later, you get localized induration, not redness alone. That firmness is due to cellular infiltration, edema, and vascular changes. As a histotech lens moment, if you biopsied a positive TB skin test, which we don't, but pretend we do, you'd expect to see dense mononuclear infiltrates, activated macrophages, and thickened dermis from edema and inflammation. We wouldn't see any antibodies, no complement, just cells showing up uninvited and refusing to leave. Some worthless but fun knowledge. TB test is read by measuring induration, not redness. Redness lies. Induration tells the truth. This slide is your immune system cheat sheet. And honestly, it's one of the most exam-friendly slides in the entire deck if you actually understand it instead of memorizing it. Let's walk through this left to right, because the immune system escalates like a badly managed group project. Type 1, IgE mediated. It is immediate. This is your dramatic friend. IgE on mast cells, antigen cross-links IgE. Mast cells degranulate, boom, histamine, edema, bronchospasm. In histology, we'll see mast cells, eosinophils, edema, and dilated vessels. Think pink, leaky, and inflamed. Type 2 is the cytotoxic. This is targeted destruction. IgG or IgM binds to cell surface antigens. There's complement activation or ADCC. Specific cells get destroyed, which are often red blood cells. Histology highlights, we'd see hemolysis, cell membrane damage, and phagocytosis of opsonized cells. Think wrong label on the cell equals immune system throws it away. Type 3 is the immune complex. This is immune glitter. It gets everywhere and causes problems. Antigen antibody complexes circulate, deposit in vessels, kidneys, joints, and the complement activates. The neutrophils arrive and release enzymes. Histologically, we see vasculitis, neutrophil infiltrates, and immune complex depositions. So we would see a granular immunofluorescence pattern. So this is where IF and IHC become your best friends. Type 4 is cell-mediated. This is the slow burn. T cells recognize the antigen, the cytokines recruit macrophages, and then the tissue is damaged over time. Histology highlights, we would see lymphocytes, macrophages, chronic inflammation, and sometimes granulomas. No antibodies. If you see antibodies, we're in the wrong column. This last slide is doing two things. It's wrapping up the hypersensitivity types and giving you a gentle reminder that questions are encouraged and confusion is normal. Hypersensitivity reactions are one of those topics where students try to memorize lists, but the real power comes from understanding what it is damaging the tissue. So here's your final mental checklist when you're looking at slides, stains, or exam questions. Is it antibody mediated or cell mediated? Is the damage immediate or delayed? Are immune complexes depositing or are cells directly attacking tissue? What would this look like microscopically? Because at the end of the day, histotechnology is about correlating mechanism with morphology. You're not just memorizing diseases, you're learning how and why tissue architecture changes. And yes, one final reminder, because it matters, Images used in this course are for educational purposes. And if something isn't clicking, that's not a failure. That's an invitation to ask. Email me, come to office hours, or write the question down and bring it to my office like a responsible science adult. So you made it through immunological diseases. Take a breath. Your immune system would approve.